Well, hello and welcome to HealthLine. I'm Jennifer Blomquist. I'm so glad you joined us tonight. If you are new to the program, we are a live show and we welcome your calls. And now, get ready for this. You can text us. So we're starting a new thing this week. All the live shows are doing this. So this is the first HealthLine where we're offering the ability to text in your questions. So let me go over how to do the phone calling and then the texting. For phone calling, we keep that phone number at the bottom of your screen, 969-2720. Again, you talk to a very nice call screener. We don't just throw you on the air. You have two options. If you call in, you can wait. They'll get you on the air to ask your question live, which is great because sometimes our guest needs to ask you questions to give you a better answer. So that's nice. You can interact with the doctor. And then the other option, of course, is if you prefer just to give your question to the call screener, that's great too. And they'll relay that to me and then we'll get your question answered. So for the texting, it is a different number. So we're going to keep that one up there as well. It's almost the same, just one digit off. So 969-2730. You can text in your question. I want to assure you that your phone number is not going to be on the screen at all. So we will keep that private. But if you don't mind giving us your name and maybe telling us where you're from, you know, you're Joe from Huntertown, that's nice if you feel okay doing that. But I just want to reassure everybody that your phone number will not show up on the screen. So just want to let you know the phone lines are open right now, the text line is open, and we welcome your questions at any point. We have a familiar face. He's been quite a few years since I've had the honor of hosting a program with him, but I'm so glad he came back, Dr. James Edlund, and thank you for joining us.
You're more than welcome.
He's got quite a title. So he works in wound care and hyperbaric medicine. You have a background as a colorectal surgeon, and then now you're specializing in the wound care, which is, in the notes you sent me, it sounds like this is really becoming a very, growing field. Like the services are needed and the opportunities for patients needing that care is definitely getting bigger.
Yep.
So
we're busy all the time.
Yeah, and you were saying before that there are even just wound care clinics now, that you can go. Is that specialized at this point?
Well, it's gotten, since I started practice a lifetime ago, we had wound and ostomy nurses and at the hospital, and all the hospitals now have wound and ostomy nurses. Even nursing homes have sometimes a visiting wound care nurse. So nursing homes, hospitals all have to provide some kind of wound care. And it's a special service because it's time consuming and it's because of the aging population that we have, it's a big problem. So I came to talk about it and tell you what we do and how important it is to take care of yourself and try to prevent wounds, and I'll talk about that as well.
I remember
entertain questions,
Oh yes, again, call, text. We got those phone numbers up at the bottom of the screen. They're going to stay right there throughout the show. I would encourage you to call in sooner or text in sooner rather than later because we'd hate to miss your questions. So it's a great opportunity to get things answered tonight for free. I remember the last time we did a show, which was quite a few years ago, you said having a background as a surgeon, you created wounds.
Yeah, they were my fault. So
I was going to say, it was kind of your fascination.
I had to learn to take care of them.
Yes.
So but, if you have a surgical practice, your life is full and it's hard to do the kind of attention that we can do in a wound clinic. Plus, we're all the wound care centers that I've heard about, and I go to national meetings, so it's all over the country, work as a team. And so that's a very important part of what we do. Surgery is a team in the OR, and wound care is a team in the wound care center.
Well, you actually were kind enough to put together a lot of slides for us, and I think we have a slide about just some important facts about wound care that people might not have thought about. So basically, you're saying this is affecting usually older patients?
By and large, but it's not exclusively older patients, but it is, the infirmities of age include wounds that won't heal. So the things I wanted is shown on the slide. When a wound fails to heal, there's always a reason. So one of the most important things we do is find the reason that the wound won't heal. Most wounds should be healed within a month, and if they haven't healed within a month, then you have a problem. An awful lot of patients come in and they've had something and they can't figure out why it won't heal, and they've had it for 6 months and they didn't tell anybody.
Yeah.
Very common for people to hide it. At any given time, and to give you an idea of the degree to which wounds occur, is that any time 2% of our population, that's a big number, will have a chronic wound. Our job in wound care is not only to treat the wound, dressings are important, but it's by far not the most important part of wound care. It's to identify the reasons that it won't heal and help with the help of several other people to heal the wound. Chronic wounds, like any other chronic illness, create personal and family problems. God bless our nursing staff and our social workers that help with this. And there's a lot of community resources that can help. We've got a listing of community resources to help people. Most communities have some way to get people to the wound care center. A lot of times they can't drive anymore, or they're many of them are living alone and lonely and don't have anybody to care for them.
Yeah.
And we also have a very blessed number of home health nurses that go to people's homes and help take care of these wounds. So I like to say it takes a village of providers, family, friends, and nursing staff to take care of people with wounds.
When you had mentioned there's, with the aging population and this becoming, more of a prevalent issue, I know we don't have a slide, I don't think, to bring up for it, but you had put together something called the age-friendly framework.
Right.
So age-friendly framework, and there are the four
M's. Yep.
Yes.
And I can tell you those 4 M's, and they are mobility, medications, mentation, and one that sometimes in healthcare we've forgotten is what matters to the patient. And you have to establish a relationship with patients. We see them by and large weekly, and so most offices see people once a year, maybe twice a year, and certainly after surgery we didn't see people very many times. We saw them as often as we had to, but wound care specialists see people weekly, and we have sometimes that they're seen more than weekly, and there's something we call a nurse visit where they come in for a dressing change that they can't do themselves. Many people, as they get older, myself included, have a hard time reaching their feet.
Yeah,
So
sure.
If they have a wound on their foot, they'll need help with that. The mobility is a big reason that some people get wounds. They get them on the back side of their heels, the back side of their knees, their bottom, especially in the middle of the sacrum, what we call the sacrum. And sometimes people get curved backs, as you've seen them walking, and they get a bone that sticks out in their back, and they'll get a sore over that. Sometimes people who've been in the ICU will have a sore on the back of their head. So
just from
we've
laying
learned
in the bed.
part of our evaluation is check the back end of the body and look for wounds. And mobility is a big part of that.
I mean, are there some people, and that's understandable, I guess, if you're, laying in that position all the time, but, maybe for somebody who does have a decent amount of mobility left, are they usually in a better situation for the wounds to be, well, I don't know, is it correct to say you can cure the wound? Or?
Yeah, we can heal the wound. We call it time to heal, or healing time.
Okay.
And, most wounds will show improvement in two weeks. You should be able to show some amount of improvement in 2 weeks. At 4 weeks, if you haven't shown significant improvement, we then refer to it as a recalcitrant wound, and then we do a lot of mid-course adjustments. Sometimes it's not obvious what the cause is, and it takes us some time to do the workup. And we have to take a careful history. Sometimes it's very helpful to have a family member there. I say to women all the time, don't send your husband to the doctor, bring him.
Yes, I agree.
Put another way.
If you want the whole story, you should go with them. I would agree.
Yeah, I say men lie to me because they're stupid and they're not paying attention. Women always have a good reason.
Yes, yeah.
And people don't really want to reveal until they're trusting.
Yeah.
And a wound is an embarrassing thing.
Oh,
and
sure,
any time of life, having a wound is just unacceptable, and we can help. Even if we can't get it to heal, we can make it better, manageable.
I was going to say, just even from a a mental, from the mental capacity of it, I'm sure that becomes burdensome, feeling, maybe even feeling like you can't go places. You don't want people to see it,
That's exactly
if it's in a place
and
that's visible.
As if it weren't bad enough with our elderly population.
Right.
Loneliness is a huge issue.
It's terrible. I agree. Yeah. Well, you had put together another slide where you talk about there are different kinds of wounds, acute versus chronic. I think it was slide 4 for the control room. I didn't realize they were divided into different categories. I don't know if you could speak to that effect of acute versus chronic.
Yeah, well, basically, an acute wound starts with bleeding, and the bleeding is a good thing because it coagulates and will stick the wound together. And then there's inflammation where it gets red all around the wound, and sometimes people think it's infected when it's just inflamed. And then the wound pretty rapidly, within 3 or 4 days, begins to heal. The redness will go away, and the body goes through the next thing where the healing cells called fibroblasts come into play. And then once the wound is covered, you have to be careful with it because it's tender, and it can take up to a year for what I used to call a pink wound to turn white. And so very often the wound will mature over the course of a year. So it needs to be taken care of once it's even completely healed. Now, chronic wounds are ones that haven't healed within 30 days.
Okay. Will they ever, or are there some that just don't ever really heal?
Every now and again we'll get some, but we have, pretty close to a 90% healing rate.
That's great.
And so you're right that some wounds won't heal, but we can always help. And sometimes it takes several changes in strategy. I call them mid-course adjustments.
Sure.
And so that's why we see people weekly, to make sure they don't go too long. And somebody comes in and then they go away for a month and they come back, and then it's often worse.
I would think the patient would like that, being seen more frequently for something that is probably weighing so prevalently on their mind.
But remember, if mobility is an issue,
correct, yeah.
if mentation's an issue,
difficult. Yeah.
If they can't afford their medications or the dressings, it's a huge problem.
Sure.
Okay.
Well, we do, of course, we're allowing people to text in tonight and to call in. Now, somebody called in, but Doctor wanted me to ask the question for them. So I'm having a little trouble seeing the screen here.
It's zinc deficiency.
Okay. They're asking you about that, if that plays a role in healing. We
don't routinely check for zinc deficiency, but you're absolutely right. We encourage protein intake, and we encourage vitamin intake at the first visit. So our first talk is about smoking cessation, and that can be delicate because they've heard it all before, and weight loss, and that can be delicate because they've heard it all before. And we want them nutritionally is a big important talk, and it's the protein intake. Sometimes people with a large enough wound will lose many grams of protein and be behind on protein even though they're eating a normal diet. So we emphasize nutrition, and we emphasize multiple vitamins. I don't think you need to do the multiple pill thing, but a good multivitamin. I always get the one with the silver bottle because that's my age group. So we just assume that they're going to be, but zinc, as you know, is what's in those pills you take to help your sore throat. Those Gagia lozenges. So I have some of those at home, and I take them when the first sign of any sore throat or anything.
Okay, good to know. Well, I want to thank Wesley because he sent us a text message and wanted to know, Doctor, if dry skin can cause a wound.
It's an absolutely marvelous question. Legs. Legs are the sufferer of dry skin, and by and large, the leg, if it has good arterial blood supply, that's very important, but the venous return is what suffers in the leg because of gravity. The legs, you're standing up, we're bipedal, and we stand up, and the blood always goes to the legs. The veins are supposed to work by having the blood return to the heart, and it's like a fish ladder. the muscle pump moves the blood up, and then the little valve holds it there. When the valves get shot, then the blood returns. It's called reflux. And then one of the problems with reflux is the skin loses its nutrition because the nutrition is gone from the blood that's sitting there. It loses oxygen, so it can't heal itself. And so it can't put the normal skin protective things that our sweat glands have for us. And so the skin gets dry. Dry skin will crack.
Yes.
Dry skin, a heel that cracks or a toe that cracks is the beginning of a big problem.
And that very
and
painful
it's
too.
particularly important in diabetics. So, lotioning with a good lotion that doesn't have any smell good in it, and there's a lot of them on the market, is a must.
What about something like a petroleum-based cream instead of like a lotion, like a petroleum? Would that work? I mean, I see ones like that they don't really smell good or anything like that, but I wonder if they were effective.
Well, we prefer the ones that are meant for the skin lotion. So there's some petroleum in them, but we don't want it to be occlusive.
Okay.
And if you're not careful, petroleum will occlude an open wound and not allow the skin to breathe. So there's a bunch of them in the list that we give out, and they're all advertised on TV.
Sure. We can't name the brands on the show,
I don't
unfortunately.
particularly want to do it, but,
yeah.
And there's a couple of them that are prescription strength.
Oh, okay.
There's a condition called ichthyosis or fish flesh skin, where you're born with the inability to heal your skin.
Yeah.
And there's a prescription strength medication that we use for particularly bad problems of it.
I'm just, and the rule of thumb is if you have an issue like that and it goes on for a few weeks, it probably needs to be addressed by a medical professional.
Anything longer than 4 weeks, a condition that hasn't healed, deserves attention.
Okay.
And of course, we don't see the vast majority of them. That's done by their primary care doctors and walk-in clinics and emergency rooms and such.
All
There's a
right.
question here.
Yeah, we do have another question. Again, this was same first name as you. James is wondering what causes a wound to not be able to clot.
Well, there's of course inborn errors where you have hemophilia. And there's a couple of kinds of that. I won't go into that. The vast majority of people that have wounds that won't clot are on something. Aspirin, clopidogrel, which is both of those are platelet inhibitors.
Okay.
And then there's the old-fashioned Coumadin, which is a rat poison, we call it.
Yeah, it's been around a while.
And then there's the new ones, the direct oral anticoagulants, and there's 4 of those on the market. Those don't require testing and don't require adjustment. Put another way, we're not able to measure them and adjust them on a regular basis. It's a much more complicated thing. Coumadin requires careful monitoring, careful dietary interventions. One of the clinics I work in has an anticoagulation unit in it, so I now know all the questions to ask, which I didn't used to. And it's a pharmacist that talks to them about, I can tell you've been eating broccoli. And it's not something they would ever accuse me of on purpose. But there's a lot of greens that have, that will make the anticoagulation medication work more. So. A wound that won't clot has a number of reasons, either something you're born with, but if you're an adult, you should have known that long ago. So there's 2 or 3 common things that people are born with, including von Willebrand's disease. And then mostly it's medication, aspirin, Plavix, direct anticoagulants, or direct oral anticoagulants, and the time-honored Coumadin, which has been around for as long as I've been in practice.
Yeah.
And even in my training, it was still there.
All right. I just want to remind everybody that you have two options tonight. From now on, we're going to allow you to text in, which is great. That's a great option, or call in. So, and we've had some folks call in, and we've had a text. So, great questions. We welcome more. We still have a few minutes left. We could easily answer some of your questions. So, the phone number again is 969-2720. And if you want to text us, go ahead and do that quickly. It's 969-2730. You brought a really nice diagram of the anatomy of skin, and I didn't know if we could bring that up. I think is that slide number 8. I bet some people probably haven't looked at something like that since they were in maybe middle school or high school science. And so
Grandpa's going to put his glasses on to help with this one.
That's okay. That's all right.
The important thing about skin anatomy is that the outer part is the epidermis.
Yeah.
And as we age, the epidermis gets thinner. And so we have an awful lot of people with thin skin.
Okay.
I've had a couple of people, I send them home with a certain dressing that will put the flap back. People tear their skin, it gets a flap.
Oh.
And you can put the flap back and hold it down.
Okay.
And that's the best
It will
way,
heal.
but sometimes they don't come to me till the flap has died, and then you've got an open wound all the way down into the fat. So there's layers. There's the epidermis and the dermis, that's the skin itself. And then the fat underneath, the subcutaneous tissue, is where the sweat glands live and and hair follicles live and send them up through the skin. So the skin of different parts of your body is different thicknesses.
Okay.
And the people of color have a different thickness of the epidermis. It's a little thicker, and it heals less well. You get hypertrophic scars and keloids with wounds that are problematic for the appearance of the wound. And if you're dealing with skin cancer looks different in people of color. A melanoma, for example, is black, and finding a black lesion on a black person is especially challenging. So we do have another question.
Yeah, we do. I was going to ask you real quickly, how far down into the skin, are some of the wounds that you treat?
We treat them full thickness is the majority of the wounds we see. Sometimes they go all the way to the bone.
Oh, they do.
So, and that's how when you see people that have lost their leg, particularly with diabetics, they've lost their leg because the bone got infected and it won't heal.
Okay. Well, I'll turn to that question. And I see you've got glasses. I don't even, my contacts aren't working tonight. So Tom, thank you for texting in. He wanted to know about MS, if that would affect wound healing. So multiple sclerosis, does that affect?
All right, well, multiple sclerosis, many of our patients have multiple sclerosis, many of them for many years. And as time goes on, if it's a progressive type, instead of the relapsing remitting, for which there are some medications now. Yeah. But we have some that are basically paraplegic or, because of their multiple sclerosis. And so that's the mobility part.
Yeah.
It doesn't exactly affect wound healing except, if you lose function of your extremity, or if you lose sensation of the skin, then losing sensation of the skin is how diabetes works to cause foot ulcers, is that people can't feel the sore, they can't feel a blister, and they walk around on it till it gets infected. And don't come in, because who checks the bottom of their feet? Diabetics are supposed to.
Okay.
And but if your mobility is affected, then you can't get your foot up there. So MS has a secondary effect, particularly with regards to mobility, does affect wound healing.
All right.
And we have lots of people with multiple sclerosis that are our patients.
Yeah, you don't think about that, somebody who's, or like you said, wheelchair ridden, and just can't get up, and you're always putting pressure on those parts of your body. It's something you didn't think about would cause problems. We only have about a minute left, Doctor, so I just wanted to ask you a couple of quick questions. I know everybody heals differently and at different, rates, so it's not really a cookie cutter formula is what it sounds like. But what advice would you give to people, especially maybe somebody who's, maybe you're a caretaker for an older person, maybe things to look for? Because like you said, a lot of people don't want to talk about it and don't want to show you, that they have this problem.
Most important thing is to protect the skin, because once it's disrupted, then wound healing becomes complicated. So as I say, we had a nurse manager when I was in colorectal surgery a lifetime ago that called it spelunking.
Oh.
And so always check the backside.
Okay.
Check the heels, the back of the knees, the buttocks, the sacrum, the wing bones, the back of the head.
Yeah.
And if you have a curved spine or any spinal defect, check that. So people get bed sores so fast and so quickly, and you just can't ignore it. We have a whole population that sleeps in a recliner, and we have a condition that we all refer to as recliner butt. And I can tell immediately when I see somebody, you know, if that's the
That they have
deal,
that.
and they're too immobile to get out of bed, so they sleep in the recliner.
All right, great points to think about. So, Dr. James Edlund, thank you so much. It's been years since you've been on. We'll have to have you back again soon. So very interesting. So
My
much
pleasure.
to share.
We're happy anytime to share.
Thank you.
Thanks, everyone.
I'm Jennifer Blomquist, and we will see you right here next week. Take care. Have a great rest of your week. Bye-bye.
PBS Fort Wayne was made possible in part by
You gotta find your people,
Good morning.
the ones that make you feel whole.
Good. How you feeling?
You look so pretty today.
Bring it together, you got nothing to lose.
Good job.
In a world full of strangers, you don't know who to trust. You can't go it alone. Everybody needs help.
Go.
You gotta find your people, then you'll find yourself.